Right. I'm going to talk to you about necrotizing enterocolitis, which I think has been mentioned probably in pretty well every talk so far. And I'm going to talk a bit about where I think, a rather personal slant, on where I think we are at the present time in preventive strategies, particularly focused on probiotics. I feel at one level I've sort of almost grown up with necrotizing enterocolitis. When I was in my first year after qualification and was a resident doing a surgical job, I was working at University College Hospital in London, and I used to, at night when I was on, I used to cover the work of the one surgeon who was a general surgeon, who at that time, this was a long time ago, this was 1973, I think, who used to cover the pediatric surgery. And one night I was called to theatres because they were taking a baby to theatre. I knew nothing about this. Was a little baby, probably in retrospect about 33 weeks gestational age. And Osmond Reynolds, who some of you might know, who was a very eminent and famous British neonatologist who's retired for quite a long time now, who was the person who did the first NMR spectroscopy in relation to hypoxic ischemic damage, etc., was on. And they took this little baby to theatre because the baby had an acute abdomen and they didn't know what was going on. And I remember it vividly, sitting in the theatre in the middle of the night, and this little baby was opened up and he looked at the bowel. And I remember him saying to the anaesthetist, "Gosh, this must be necrotizing enterocolitis. I've read about it." And this was on, you know, at that time, what was the biggest, most active neonatal unit in the UK. And I have to say that baby died within about 10 minutes of that being said, and died on the table. And I remember this, and terrible, the anaesthetist was so shocked because he'd never had a child die on the table before. And I remember thinking, gosh, what is this extraordinary disease I've never heard about? And here we are, years later. And I was asked last week to go and give a talk in the UK somewhere about necrotizing enterocolitis. And they gave me, I can't remember exactly what the title was, but it was something like, what on earth can we do? As if, and there was a sort of cry of desperation almost in the title of what we as people looking after small preterm babies are going to do about this particular problem. So what I'm going to try to do in this final talk today is to just talk a little bit about the disease in general and the risk factors, which I think we all know, but in a sense I think they also help us to understand a little bit about what's going on. Very, very little about clinical presentation and diagnosis, and there was a discussion going on at lunchtime that made me think, well, I didn't actually know anything about that anyway, because obviously it sounded as if things were changing in how sort of things you can do. And then a bit about the pathogenesis and the management, and then finally to talk a little bit about prevention, and as I say, specifically focused on the role of probiotics. And as with everything we've been talking about, I suspect there are different experiences and different views in the room and different interpretations of data, and I'm sure different practices. And I think at the moment probiotics are one of the really, really interesting issues around the world in terms of the management for these babies. I think one of the things that's rather bedeviled research into NEC is the fact that we rather lack a good working standardized definition that we can use. You know, we're all getting very interested and we're very good or getting very good at having standardized neonatal data sets, collecting data, comparing data, using it for benchmarking and things, but we've rather lacked a good working definition for necrotizing enterocolitis. And this is a very clinical definition which wouldn't really do. It's subjective, and it wouldn't do if you wanted to collect and look at the incidence of NEC across hospitals in Italy. You'd have to have something more precise than this, and we've rather lacked that, and so different people use different things. Its incidence in babies, very low birth weight babies, is of the order of 7%, and of course it becomes more common as the gestational age becomes lower. It has high mortality, variable rates quoted, but it is high in all series. And of course, there are differing views about the indications for actually taking babies for surgery, and things change over time, and they change in different places as to what stage and in which babies you should operate. But I think it's fairly accepted that of those babies who people do select to go to surgery, the mortality in those babies is particularly high. And what, of course, has become increasingly clear as we've been able to get better data on follow-up for babies is that those babies who survive necrotizing enterocolitis have compromised outcomes in terms of developmental delay and poor growth. And it's not just the babies who've had NEC that's operated on. This is also true of babies with medically treated necrotizing enterocolitis. And one of my great sadnesses, and I possibly said this yesterday, and it was because we got so hung up and obsessive about definitions, that in the IPOKRaTES studies we know about surgically treated necrotizing enterocolitis, but we don't actually have data on medically treated necrotizing enterocolitis, and I think that is a really severe criticism of the data set that we used. Now, there's all sorts of lists of clinical risk factors, and these things have sort of guided us and helped us and misled us, I think, over the years. We don't see necrotizing enterocolitis in stillbirths, and I think that's pretty much generally accepted. We know it's more common in low gestation and low birth weight, and I think that neither is there really any argument about the fact that the particular group of preterm babies who are hypoxic and acidotic in utero, as picked up by having abnormal Doppler blood flow studies, are at increased risk. And that is true, and as it is true that babies with big patent ductuses may be at increased risk. And that, of course, has made a lot of people interested in the fact that how important gut ischemia was in the pathogenesis. And I think that sort of slightly sidetracked us for a long time. And it was interesting that during the lunch hour, I was listening to people talking about Doppler blood flow studies of intestinal blood flow. And there have been quite a lot of people around the world who've been interested looking at gut blood flow, which may well be reduced, and looking at blood flow responses to enteral feeding. And in the normal situation, you'd expect an increase of superior mesenteric artery blood flow when you feed. And there's some data that suggests you don't get that adaptive response in babies at risk of NEC. And I think it's made us rather focus on the very early life of these babies in the first few days after birth. And I think it's slightly misled us from what I think now is that the more important things that are going on. Although I'm not arguing for one moment that ischemia isn't important in this situation. There are also data that suggest that there is at least some protective effect of feeding breast milk as opposed to formula milk. Some people might say to you, but you don't get necrotizing enterocolitis if you don't feed at all. I don't think that's absolutely true. I think absolutely. We've, all of us, I think, occasionally seen NEC in babies who have not been fed. But it is more, it seems, well, it's I don't know. I don't really know. I'm not even sure it's true to say it's more likely if you're fed, because if you're not fed, there's something going wrong and a reason why you're not being fed. But certainly breast milk has a protective role. But the data that are always quoted are the classical studies of Alan Lucas in the UK, and I don't really think those are very relevant to the babies we're looking after now. He was looking at a population of babies below 1,850 gram, really big babies in comparison with the populations that we're looking at now. And then there's this very interesting association, which we mentioned this morning, of in the prolonged associations with the prolonged use of antibiotics with necrotizing enterocolitis. And the reference I've put here is to the Cotton paper, but in fact there are now other papers noting this same association of antibiotic use with NEC. So it's an interesting list and then of associations. And then we've got how we describe the clinical picture. And if you look at papers about necrotizing enterocolitis, if you look at trials where NEC is one of the outcomes, it's usually categorized as to whether or not, by the Bell staging or adapted Bell staging, modified Bell staging, and real true Bill NEC is generally thought to be Bell stage 2 or 3, and suspected NEC, Bell stage 1, is really no different from any baby who possibly has query infected, query something going on. There's nothing really that pins it to necrotizing enterocolitis. On the other hand, I think most of us really in ordinary practice, we wouldn't look at many of these things. They're possibly guides, but in practical terms, it's the baby who has feed intolerance, a distended, a tender abdomen, and then the absolute pathognomonic signs of whether or not the baby has intramural gas with or without perforation and intrahepatic gas. Now, I don't think there is no point in showing these pictures, and I don't think there's probably any point in showing you these X-rays. They won't show very well, but I don't think that it really matters. But I do think, well, possibly it's just because I'm not very good at looking at X-rays, and I've struggled over the years, but I do think that really severe, extensive intramural gas might be easy. But possible query intramural gas, I think, is an absolute nightmare. And I'm sure we've all been in the situation of 2 or more people looking at the same X-ray and at the same time saying, yes, there is, no, there isn't. And I had a tremendous up and downer the other day with one of my colleagues, and I'm sure I was just looking at normal meconium in the bowel, and he was adamant that this baby got frightful NEC and got a lovely soft tummy and was completely well as far as I could see. And I do think it's a difficult radiological sign, or can be a difficult radiological sign. Sometimes it's very easy and you wouldn't have a clue from that. And sometimes it's really easy and that you wouldn't have a clue, but I assure you that's a really easy one. And this one's got fantastic intrahepatic gas on it, but sometimes that can be difficult too. This is very easy, even with an X-ray that's showing very badly. But of course, the one that's sometimes difficult is particularly difficult here. And this is the one that, of course, is missed, is the one where somebody just takes an AP picture and you can't probably see, but you can just about see. And then, of course, the boss walks in the morning and says, why didn't you ring me about that perforation? And they all go pale. Because, of course, they haven't spotted the gas against the falciform ligament, which, of course, and because many of us don't routinely. I was talking to a surgeon the other day who was going on and on about how we should always take lateral shoot-throughs, and I don't think many of us do that. Unless we're particularly concerned. But I think as neonatologists we need to get quite slick at looking for this sign, which I don't think you can really see there. So I think the radiology can be very easy, but it can also be very teasing and very difficult. The other point, of course, is that what we find at surgery can vary enormously. Sometimes we have very localized disease, and one does sometimes wonder about the etiology of that, and embolic phenomena, and of course those very early perforations which aren't NEC at all, which we see sometimes in the terminal ileum, which are very localized. But of course the really difficult thing for the surgeon is when he sees severely affected gut, about really knowing how much of that gut is obvious. If it's obviously necrotic, it's obviously necrotic, but just how much of it can be salvaged. And most of the surgeons I know do all they can to save as much as they can, and they might even bring out multiple stomas, leave multiple little bits of gut in there in the hope that some weeks down the line they can go back in, and some of them will have completely gone away and others will have recovered, and that they can join them up again. So what is going on in these babies? And as I say, it's very interesting because I think that, it's possibly been different in different places. But I know that we've been, I think, rather over-focused on the things that go on early on the baby who's been hypoxic in utero, and we've thought a lot about what goes on shortly after birth without really looking at the epidemiology of it. And looking in more widely at the clinical picture, which I think this is a very interesting slide from Joseph New, and it shows the average age of onset of necrotizing enterocolitis in preterm babies against their gestational age. Now, of course, we sometimes, and in the very early days of NEC, we saw it in bigger babies, we saw it in relation to exchange transfusion, we talked about umbilical venous catheters and such like and so forth. And it might be the same end disease. The changes in the gut might be the same, but I think that the background to that disease is probably different from what we see in these little preterm babies. And what is shown very clearly here is that the more preterm the baby, the later the presentation of the disease. Now, I know there are many exceptions to this, but on the other hand, I think we're all aware in our practice of the little baby, often a growth-restricted preterm baby who we've had difficulty establishing enteral feeds. We start, and then the tummy's a bit distended, and we stop again, and then we have an episode of suspected infection, and the baby gets some antibiotics, and we stop and start with the feeds, and then eventually we get the baby onto full enteral feeds, and we begin to relax, and then at about 4 to 6 weeks of age, in the space of a couple of hours, that baby collapses with fulminant disease, with a distended, very tender abdomen and going rapidly on to perforation, and it's the most devastating thing on a neonatal unit. The other thing, of course, which, I mean, in a sense, I'm talking about NEC, but the other thing, and I think the two things are related to some extent, is equally that baby could have gram-negative sepsis, which, quite frankly, is as much of a problem, I think, as is necrotizing enterocolitis. Possibly a bit less common, I don't know. So there's that, and then there's this very interesting data, and this is very recent data. There's an earlier paper, but I think these are very nice, very recently published data from the Canadian network. And what we're looking at here in the blue is the incidence of necrotizing enterocolitis by gestation. And this is interesting in the context of what I was talking about yesterday from the IPOKRaTES data, because, of course, it makes it look as if in the extremely preterm baby, the incidence begins to fade away. But, of course, what's happening is that those babies are dying. And they're dying in the first week of life. But once you get through the first week of life, as increasingly our 24, 25, 26 weeks gestation babies do, then we get this very high incidence of necrotizing enterocolitis, which begins to fall away in the slightly more mature babies. But what we've got here in the pink line is the post-menstrual age at the onset of the disease. And that is really very interesting. And this isn't the first series to have shown this, that it seems to peak at around 32 weeks post-menstrual age. And I think that that fits in very nicely with the picture that many of us now see on our neonatal units. And it's really that makes one think, hey, this sort of idea we used to have, and we used to measure the gut blood flow and look at it and worry about when we should start feeds and delay the starting of feeds in the first week because we're worried they're going to get necrotizing enterocolitis. Actually, we're wrong, because in fact, this is when they're going to get necrotizing enterocolitis. It's in a few weeks' time. There's something else going on. It's more complicated than that. The story is more complicated. And I think that these are really very, very important data. So what is going on? Well, I think the thing that we all know so well now from a number of studies and from this extraordinary fulminating disease which we deal with is that this is a multi-system inflammatory disease. And of course, that's why in the babies who recover, we see such devastating long-term effects on them. And there's a number of elements, and of necessity we need to be fairly sort of simple about it, but we need to think about the bowel and the bowel in the preterm baby and how it adapts to extrauterine life. There's the intestinal barrier, there's this business of the flora, which obviously I'm going to come on to, and the immunology. And of course the gut, as we all know, is an enormously important immunological organ. It is an essential part of our immune system. And this is a very sort of simplistic cartoon, but just to remind us of what is going on and the mechanisms in the full-term baby. that protect the baby. The gut moves at peristalsis, so pathogens and nasty things get moved on. We've got a nice level of mucus over the epithelium with lots of lovely IgA in it, and we've got these tight junctions between the intestinal epithelial cells. In the preterm baby, it's not like that. The tight junctions are impaired. The gut, we all know, doesn't move as well. We all wish we could get it to move a bit better sometimes, but it doesn't move very well. You don't have very good mucus production. You don't get that lovely, rich sort of mucousy IgA-rich layer there. And one of the results of that, of course, is that if there are pathogens, pathogenic bacteria there in the gut, and there will inevitably be pathogenic bacteria there in the gut. We did some work, published some work a few years ago across a couple of hospitals in East London, looking at the bowel flora in our babies on our neonatal unit, and it was absolutely horrifying, quite frankly, the number of pathogens that they were colonized with very early on, and the patterns of antibiotic resistance of those pathogens. They were resistant to antibiotics that I'd never heard of, and that we'd certainly never used on the unit. And it's very interesting how these organisms adapt and share genes, and it was really quite alarming. So what about the intestinal flora? What on earth is what's that bit of it about? And we've referred on several occasions in the last couple of days to this fact. I've already said today that only of me standing here in front of you, only 10% of my cells are human. The rest of me is a sort of wonderful conglomeration of a diverse population of bacteria, and we all know that our good health is absolutely dependent upon the commensal relationship that we have with those bacteria. And probably a lot of other things too. So what happens in the term baby? Well, as you know, for practical purposes, I know that as people do more and more molecular studies, they say the gut really isn't sterile at birth. There's all sorts of interesting things there, and if you culture the amniotic fluid, there's all sorts of interesting things and organisms that we've never heard of, and we've no idea what they do, and we've no idea if they're doing good or bad. And there's so much work for people to do. But for practical purposes, the content of the gut is sterile at birth. Well, certainly that's what we still tell the undergraduates. And of course, what happens in the normal situation is that the baby is born vaginally. The baby is born usually looking at its mother's anus. Might not be, but usually. Unfortunately, in modern obstetric practice, they probably will have cleaned the mother up and put horrible antiseptic creams and all sorts of other ghastly things there. I, when I was a houseman, said I wanted to do a randomized controlled trial of giving babies a little bit of maternal feces. I can't believe I said that, but somebody told me the other day it was true, and I really had said it. And I wish, in a sense, we could have done it before they invented ethics committees, but it would be very difficult to get it done now. But what happens, of course, is that baby is born vaginally, put on the mother's skin, stays with the mother, is breastfed by the mother, surrounded by little brothers and sisters who don't wash their hands as frequently as they should. And what happens is that baby rapidly, from the time of birth, begins to become colonized by a flora which resembles that of its mother. And particularly if that baby is breastfed, that will be dominated by bifidobacteria. It'll be dominated by commensals anyway, but particularly by bifidobacteria in the breastfed baby. And it will be diverse, and there will be lots of different strains there. And of course, the situation in our little preterm babies is different. They're more likely to be born by caesarean section. There haven't been very many studies, but what studies there have all been agreed that there is less microbial diversity, there's slower acquisition of organisms, fewer commensals, and there are more of these nasty potential pathogenic organisms there. And of course, this whole situation is exacerbated by prolonged antibiotic use. And I don't know what you're like on your units, but I know what we're like, and we are not nearly as good as we should be about promptly stopping antibiotics when there's no longer a real indication for their use, even if there was an indication to start them in the first place. We do know that if the preterm baby is given fresh breast milk, that we get more bifidobacteria there. And we do it, certainly some of the earlier studies, I think if you breastfeed the baby, the preterm baby, the situation isn't quite as bad as it looked in some of the early studies, but that there aren't very many data. What are those organisms doing? Well, they're doing lots and lots of different things. They are, of course, modulating the metabolism of iron, amongst other things, which in itself modulates what organisms may or may not be there. But I put this up really just to give you the sort of a feeling of the range. This is a very, very good review, incidentally. But just to give you a feeling of the range of things that these organisms are up to. They're all about maintaining the health of the intestinal mucosa, maintaining its functionality in terms of the various immunological functions, regulating the environment in terms of the pH, what organisms may or may not be there, competing for sites with other organisms, generating short-chain fatty acids, which are important for the health of the colonic enterocytes, involved with IgA production, and involved down here with T cell function and macrophage production, and the question of whether or not inflammatory or anti-inflammatory cytokines are produced. Now, if we've got young people wanting to do research, it just seems to me, I mean, this data, most of it comes from experimental animals. There are some data in immature experimental animals, and the immature experimental animals behave differently from mature experimental animals, and different commensal organisms do different things at different stages of development. And immediately you begin to say, gosh, if you're going to begin to use commensal bacteria therapeutically, what on earth do you use? What properties do you want them to have? And in a sense, it is a very, very complicated area, and it just highlights, in a sense, the simplicity of our present situation, and which I think years down the line, if probiotics really are found to be useful, I think what we're doing now will seem to be very primitive, because those organisms we're using are the organisms we can get. They're rather than organisms that we've chosen for good scientific reason. So what's going on? At full term, now when I'm talking to the undergraduates, and they ask me to talk about physiological adaptation at birth, and I used to talk about the lungs and the heart, and then I got a little bit less narrow-minded and talked a bit about nutrition and the extraordinary change that takes place from getting continuous nutrition across the placenta to intermittent nutrition via the gut. But now if I'm asked to talk to them, I try to get through all that and leave myself a bit of time to talk about one of these other extraordinary things which takes place at birth, which is that suddenly this organism, which this into the inside of the gut, which has not been exposed to pathogens, will be exposed to organisms that are potentially pathogenic and tolerates them and doesn't set up an inflammatory response and become unwell and get into trouble, and keeps them in our gut and out of our body. So how does that happen? How does the full-term baby tolerate organisms that are potentially pathogenic? Well, as you know, the stomach contents aren't very acid at birth, but we develop gastric acidity. Our gut, as we've already said, moves. And then we have this very complicated and very fascinating innate immune system, and the toll-like receptors, of which many types are now identified, are fundamental in this, in recognizing particular patterns on cell walls and knowing what's dangerous and what isn't dangerous, and either setting up an inflammatory response or not setting up an inflammatory response. And that's a very primitive way of putting it. But basically, in the preterm baby, the gut really does seem to be immature. It's not prepared to meet pathogens in the way that it is at full term. And what happens in the full-term baby, the recognition, particularly by TLR4 cells, you get release of 1-kappa B, which inhibits inflammatory cytokine activation. This is underexpressed in the preterm baby, and a whole number of mechanisms in the preterm baby. What seems to happen when things begin to go wrong, when possibly the balance in the bacteria in the gut, and we know so little. There have been very few longitudinal studies of what is actually going on in the days leading up to an episode of NEC, because that's obviously a very difficult thing to study. Some people have, and increasingly people have collected serial stool samples and are then going back and looking at the cases that have developed necrotizing enterocolitis and compared them with the babies who haven't developed necrotizing enterocolitis, doing case control studies. And the messages really aren't clear yet, but using molecular methods, the question is, can we identify a pattern whereby the flora is changing? There's becoming a predominance of pathogenic organisms, perhaps, in the hours and days before the onset of the disease. And preliminary data suggests that possibly that may be true. But we're just beginning to scratch the surface. But definitely the final pathway seems to be that the gut says, this is pathogenic, I am going to set up an inflammatory response, and a very uncontrolled inflammatory response, an exaggerated inflammatory response, is set up with excess production of platelet activating factor, of IL-8, and other pro-inflammatory cytokines. And we get that acute clinical picture, which sadly we all know so well, and the acute systemic illness. And this is a cartoon which doesn't sadly show very well, a very nice cartoon from another fabulous review, which was in the New England Journal last year, with the more normal situation on this side, with nice little commensals, toll-like receptors here, IgA molecules, and the intestinal epithelium intact. But then possibly we get the microbiota, the population of organisms here in the gut changes, possibly because the baby's just been on antibiotics, no milk, and the situation just gets to a point where the pathogens begin to predominate. There is probably, possibly, not in all babies, but in some, possibly a genetic element, polymorphisms are beginning to be identified in those TLR cells. And the whole thing begins to break down, and we get this fantastic inflammatory response with opening of the tight junctions and passage of pathogens, at least into the bowel wall, because of course it's fairly unusual in NEC for us actually to get a positive blood culture. We do sometimes, but not very often. So it's that sort of thing that's going on. It's an immature gut, an abnormal bowel flora, and bang, it just goes wild in a sense. So what do we do? How do we treat it? Well, it hasn't really changed much over the years. We stopped feeding them. We give them parenteral nutrition. We used not to. We used to stop feeding them and starve them for 10 days. A long time ago, because we had such terrible times getting lines to give TPN and didn't really have anything much to give anyway. But we provide parenteral nutrition. We treat them with antibiotics. How long we should keep them nil by mouth? I have to say, I feel increasingly that if the baby's settling down and the gut hasn't perforated, I'm really keen to get fresh milk into there as early as I can. But there are very few data out there actually to support that. There are some. What antibiotics do we give? Well, we give very broad spectrum antibiotics, and we usually give metronidazole with them. It might be a good idea, but it's not underpinned by good evidence. It's the practice, it's what we do. And how long you give them for. Many people give 10 days, but some people give a week, and some people give 2 weeks. Some people stop the metronidazole after about 5 days. I always try to stop the metronidazole because I'm not sure it's making any difference, and I think it's pretty nasty, toxic stuff. So I stop the metronidazole after 5 days, but I don't have any evidence for doing that. It just doesn't seem to make any difference. So that's what I do. And then people argue about whether you should stop the antibiotics and have a gap and then reintroduce feeds, or whether you should give the feeds and then stop the antibiotics. And there's no right and wrong way. There is not evidence to underpin any of these things in this disease, which we have a lot of in our neonatal unit. Surgery, as we know, is pretty desperate. It's about decompressing the bowel. It's about removing necrotic bowel and hoping and praying that you're going to be able to salvage enough bowel and hopefully also the ileocecal valve so that that baby will be able to maintain adequate enteral nutrition after recovery. Unless it's just an absolute emergency in order to move the baby and the baby is so distended with perforation, certainly there is no place for drainage other than just to decompress to help you ventilate the baby in order to get the baby to the surgeon. There was a period a few years ago where if the baby perforated, we popped a drain in and just hoped things would settle down and get away with it. But I think the evidence is now really very much the case that that is not helpful, and that if a baby has perforated, that baby, provided the baby needs surgery. What is clear is that this is, as I said yesterday, as we get better at getting babies through that first week of life, through the first 2 weeks of life, this is an increasing problem for us, as is late onset sepsis. And mortality and morbidity are high. The disease is overwhelmingly rapid in onset and devastating, and the idea that we're going to be able to develop a therapy that says, oh, this baby's got fulminating necrotizing enterocolitis, that we're going to be able to pull something off the shelf and give it to that baby that will make it better, I think really that is highly unlikely. And I think that the only way, to my mind, to get through this and to make the situation better than it is for us to be able to identify and develop successful preventative treatment. We need somehow to interrupt this sequence of events, to change the situation so that this catastrophic sequence of events is less likely to occur. Now, this is adapted from the review in the New England Journal last year, and it's just a list of possible preventative strategies with headings of evidence of safety and efficacy, evidence of efficacy, poor safety, efficacy in animals, no human data, proposed interventions with little evidence. Hasn't changed much since this was published. Interestingly, they put probiotics here, and I thought some people might find that, might disagree with that. Some people might even say the safety is good, but we're not quite so sure about efficacy. So I put it in both of these places, and I don't know where people would put probiotics. But certainly breast milk is a good thing. There's no question about that. But using breast milk early is not going to solve the problem of necrotizing enterocolitis. I'm sure we need to be better than we are about how we establish breast milk feeding. But again, it's not going to be the whole answer to preventing necrotizing enterocolitis. The latest systematic review of the many trials that have been done of antenatal steroids shows, I think for the first time, that there is a preventative effect on necrotizing enterocolitis, which is good to know. There was interest a few years ago in giving babies aminoglycosides enterally and clearing the gut and sort of getting rid of the pathogens, but I don't think anybody does that now, and I certainly don't think any of us would be particularly keen on giving. You do it. Did you put your hand up?
Yes.
You still do it?
We still do it. This is a hospital in Austria. I think it's the only place in the world probably does it. Extremely, I've been there for the last 2 years now. We have a very, very low rate of NEC.
Yeah.
We have 0.4% rate of NEC.
You won't know whether or not it makes any difference, unless you get more.
We do so many other things. We have a multiple of like prophylactic treatment methods.
Yeah.
So we give gentamicin orange to all babies who are admitted.
How interesting.
Routine, we give probiotics. We give
How interesting.
antibiotics.
Do you give them breast milk?
Yes, we have a breast milk bank, so they all get breast milk, and so there's lots of issues that come into it. We can't really identify what's the reason, but nobody dares stop doing what we're doing.
Doing any of them?
Yeah. No, we'll stop it because it's doing so well. That's the issue.
Right, right. Well,
so one of the things is working. Something is working very well, but we don't know.
it might be that there's not very much anyway.
It could be that it's just pure.
That's right. Well, anyway, I didn't think anybody did it. And I think most of us aren't particularly keen on the idea of sterilizing the inside of the gut. Arginine is a substrate for nitric oxide production. Probiotics I'll come back to. Really no data about these things. Virtually no data about prebiotics. Lactoferrin is really interesting because, of course, there's work in Italy looking at bovine lactoferrin, focused primarily, I think, on late onset sepsis. There's a trial, a multi-centre trial, which has been recently funded in the UK by the Medical Research Council to look at bovine lactoferrin. It's been piloted for a year. I think we've had such trouble with probiotics that they want to know they can do it before they give them a lot of money. So it's being piloted across 3 or 4 units before it becomes more generalised. But there is a big trial planned of bovine lactoferrin. I can't remember how many babies, 1,400, I think. I looked the other day and I couldn't really find any evidence worth discussing for these various interventions. Which brings us back really to the probiotics. Although I would mention one other thing. I went to a meeting last week of a neonatal network in England, in the east of England, and they were very worried because they thought they had a lot of necrotizing enterocolitis. I don't really think they had any more than anybody else. But they've introduced a care bundle jargon across their network. And this is really driven by a group of doctors and particularly by the nurses. And it's about hygiene, it's about minimizing use of antibiotics, and it is above all about promotion, which is what I was interested about. I was asked you specifically about breast milk. It's particularly about the early expression of milk and provision of fresh breast milk, not bank milk. They've got all their women expressing between, certainly by 6 hours of age, and the babies receiving breast milk, and they've managed to apply this across a huge network. Right. They've applied this across a big network of hospitals with about, I think it's about 16 hospitals in East Anglia, and they're now, after about 18 months, getting really good compliance with the care bundle. Very high usage of breast milk very early on. Of course, it's not controlled. They've only got historic data to look at it, but their very preliminary data would suggest that they really are seeing earlier establishment of feeds, less NEC, less sepsis, but it's completely uncontrolled data. But it's an interesting, that sort of thing probably should be on a list like this. Okay, so probiotics. Well, of course, the hypothesis is nice. It feels good. In terms of what I've said, the idea that these babies are short of commensal organisms. Their gut is really vulnerable. It is immature. The wrong things are there in order to protect these babies and prevent inflammation. So the idea that if you give some of those commensal organisms, you can actually modulate the bowel flora, make it look a little bit more like it would do in the full-term baby. Okay, the underlying gut is still immature, and I don't think that anything is going to really completely solve this problem, although it's interesting that in many places it's very unusual. But that you will strengthen the barrier function of the gut, that you will improve the ability of the gut to make IgA, etc., and to deal with potential pathogens, and you will see less NEC, and one would hope you would also see less late onset gram-negative sepsis, because of course when we get a gram-negative sepsis, in probably the vast majority of cases, those organisms have got into the bloodstream by translocation across the bowel wall. What is a probiotic? Well, this is the simplest and most satisfactory definition that I know. Some people would argue whether or not, of course, it really needs to be live, and there is some work looking at killed commensal organisms, and indeed in probiotic trial that I'm involved in, there was a long discussion about whether we should have a third arm of killed organisms. The attraction, of course, being that if you give dead organisms, you're not going to run the risk of getting a septicemia with the probiotic strain that you're giving. Although, hopefully, in reality, that's a very low risk anyway. So a microorganism, and any microorganism, doesn't have to be a bacterium. There are examples of fungi being used for childhood diarrhea in adequate amounts confers a health benefit. So it becomes a probiotic because it works, basically, because it has a commensal role. So how good is the evidence that they work? Now, before we get on to this, can I just ask how many of you work in hospitals where you routinely give probiotics to your very low birth weight or extremely low birth weight, I don't mind which group, of babies? Actually, I thought it would be more than that. I thought it would be more than that. I did a debate about this at the last ESPR meeting in a room full of hundreds of people. Only about 2 people put their hands up. I thought we were being timid. I'm interested that it's not more than that. Right. Well, this happens to be a forest plot from the updated meta-analysis from Western Australia. There has been a Cochrane review published subsequent to this. It includes a few more trials. I have to say, I think they're not very good trials, and the message is the same. Certainly in the UK, it was this publication, which was an update of one published 3 years earlier in the Lancet, which really people sat back and looked and said, hey, you know, we've got a terrible problem on our unit. We've got babies who we thought we'd got through all their problems. We've got babies dying with necrotizing enterocolitis. We've got babies with lifelong problems secondary to necrotizing enterocolitis. How can we disregard these data? So there are 11 trials, 10 of them with data for necrotizing enterocolitis. They're mostly pretty small. The biggest of these trials is an Italian trial here, which I find a very difficult trial to understand, because there's a lot of probably some of you, we were involved in this trial, Roberta, so you can perhaps tell me about it. Interesting, it is the biggest trial ever published so far of probiotics. You can see as regards necrotizing enterocolitis, it didn't show a statistically significant reduction in the active arm. But what was interesting about, there's a lot of discussion, one of the primary outcomes was urinary tract infections. And there were more urinary tract infections than there were episodes of necrotizing enterocolitis in the placebo group. And also, the mortality data are very strange, and there's clearly a misprint in this review. In fact, there's a tenfold difference in the quoted mortality between this review and the Cochrane, and I gather that the raw data are no longer available, so we can't go back and check the mortality in these babies. But this is NEC. Now, there are 4 trials here which individually show statistically significant reduction in NEC. 2 of them were both published very close together in 2005. One's a Taiwanese study, and one is a study from Israel. And then there are 2 more trials here from the same group from Taiwan. This is a multi-center as opposed to a single-center trial. Interestingly, both show less NEC. This one showed less blood culture positive sepsis. This one showed a statistically significant increase in blood culture positive sepsis in the active arm. I'm not going to talk about that any more, it's a different subject, but I think it's a very interesting point. And this is an Indian trial. These aren't very big trials, but as you can see, these trials individually have got fairly wide confidence intervals, but if you do the meta-analysis and put them all together, you seem to get a very clear message that if you give probiotics in the context of a randomized controlled trial, you are going to get a massive reduction in necrotizing enterocolitis.
I think one of the calls that this meta-analysis had was that many of those trials, when you look at them individually, their outcomes, they didn't even look at.
Do you want to give the rest of my talk for me, Doctor?
I will not say anything else.
They can interrupt. Well, you might well be going to say, but I mean, probably, we'll get there. Lots of problems with these trials. Interestingly, and I'm not going to show you in the cause of bringing the day to an end, they didn't show a difference in blood culture positive sepsis. It appeared to have no effect at all. That in itself is strange, if what I've said about how probiotics might work is true. It may be just the way they're defining blood culture positive sepsis, because they're including everything. But they did show reduced all-cause mortality. And a lot of people, if you read the discussion to this systematic review, there's some very emotive comments about how, in the face of this evidence, how can you do more randomized controlled trials? How can you not give routine? How can you deny parents, really emotive stuff, the possibility of their baby having this therapy? And what I would say, particularly to my mind, in looking at this, one of the things, I was talking to a group of junior doctors who were talking about critical appraisal the other day, and I said, you know, if you're going to look at data like these, and if you're going to make a change of practice in your unit because of a systematic review like this, you should look at the individual studies. Don't just look at the systematic review. Look at the individual studies. And particularly, I think in an age where so many of us read our journals electronically, as opposed to sitting down in the library with the journal, we miss the correspondence in the weeks and months after these studies are published. And I think we really ought to look out and see what people are saying about them. Because there were two commentaries published with this. One, I happen to know, was unsolicited and was very strongly in favour of doing no more trials and, you know, go ahead. How can you deny parents? Whereas the other one, which was a commissioned commentary from Sol, was much more considered. Hey, just stand back a minute. We need to think a little bit about this, and we're going to think a little bit about it now. Because what I would say to somebody who looks at that and says, I'm going to start giving them probiotics, I'm not going to wait for more trials. Obviously, you need to look at the individual trials and ask the question. And Mario, I'll give him free rein afterwards because he's probably going to be much more constructive in his criticism of the trials than I am. But you need to look at those data and ask if they're really reliable. You also need to say, are the babies going into those trials like the babies on my unit who I'm having difficulty with establishing feeds and who are getting necrotizing enterocolitis? Are we confident about safety in the babies that we're looking after? And of course, there's another very important question, I think, with probiotics, which is not common. You know, if you're giving an aspirin or you're giving EPO, assuming you follow the prescription and give it to the right baby, only the baby you give it to is going to get the medicine you give. If you give a live bacterium enterally to a baby, that baby is going to excrete that live bacterium, and that live bacterium is almost certainly going to spread to other babies in the unit. In trials, it will spread to babies in the placebo arm, and in fact, it will spread to other babies in the unit who aren't in the trial at all. So you need to be absolutely confident of its safety. And you need to think about what that means for those babies. Now, I'm just going to make some very general comments about them, so I probably shouldn't have shut Mario up, because I elected not to go through them blow by blow, but to make some rather general comments about these trials, and we can discuss them afterwards. But if you look at the exclusions in those trials, for instance, the early trial from Taiwan, the first trial, published trial, which showed a difference, didn't recruit babies till the end of the first week. They all had to have lines out and to be stable. The Israeli babies had to be stable. They don't tell us about the exclusions. In the second two trials, which showed a statistically significant benefit, they excluded they excluded formula-fed babies. They excluded breastfed babies. I can't actually remember which they excluded. They excluded one or other, which was in itself rather bizarre. The Indian trial excluded any baby who died from anything other than NEC. And if you look at the exclusions, there are very small babies in all of these trials being excluded. And in a lot of the data, and I have got slides with all the data on, there are a lot of babies being excluded who die, and in many of those babies, the cause of death is necrotizing enterocolitis. So you begin to wonder, whether the babies who really are at risk of NEC, the babies who certainly worry me, and I suspect worry most of you on our units in Europe and in relatively developed countries, whether those babies are being included in these trials. It's also the case, and I think in large part this is because of having to achieve blinding, which is difficult, as I discovered myself when I tried to do this. The intervention is given usually in milk. So the babies are beginning to be milk fed. So the little baby who I say, I think I'm going to start feeds today, and the nurses go, I don't want you to do that. And the tummy's a little bit distended, and you stop. Those babies aren't getting into these trials. These babies are being milk fed. Now, I think that in large part that's in order to achieve blinding, but it's not really discussed in the discussions of these papers. There's also a point that none of these trials in the primary report publishes any data about whether or not the babies are actually colonized with the probiotic strain being given. Now, bifidobacteria are sensitive to penicillin. We know if you give a lot of bifidobacteria, you can actually still get colonization if you give penicillin. But some of the babies in the active arms won't be colonized. Some of the babies in the placebo arms will be colonized. And then if you've got a unit, and I think this is probably going to vary, of course, with the design of your milk kitchen, the design of your unit, the degree of separation between your cots. But in units that are fairly crowded, it's probably rather different from in units that aren't rather crowded. And it might be that results of probiotic studies aren't as easily generalizable as the results of trials of more conventional medicines. It may, of course, be, if you think that one through, that we're underestimating the benefit of giving probiotics. If you've only got 70% of your active arm colonized, and 20–30% of your placebo arm is colonized, and you're showing a difference, then there's a huge difference. But we don't know, because it hasn't been looked at in that detail. In point of fact, most of these trials, they involve different interventions, and most of them are mixtures of organisms. And what I would hypothesize, but I don't know, is that if you cultured the stools of those babies, you'd find that different babies are colonized with different mixtures of those organisms that are in those products. So lots of different products, and there's a lot of lack of clarity, let's put it like that, in the reports of these trials about the methods of randomization, the methods of blinding. And, people say, oh, there's, the trials are good, the funnel plot does this, that, and the other. But quite frankly, when you drill down into these trials, they are not as good as they should be, and they are small. And then people say, yes, but the effect is so big that it can't be overcome. But that's not true. And we've now got the example of immunoglobulin to treat sepsis in the newborn. I know there weren't as many trials as there are of probiotics. But you come along with one big, well-designed trial, and you completely reverse the previous impression from adding together small trials that weren't very good. So I personally think this is very pale, and it doesn't really matter. This is a slide from a recent review, and I put it up merely to demonstrate to you the fantastic range of organisms that has been used in these trials. Most products contain a lactobacillus. Most contain, in fact, no, I don't think, or most contain a bifidobacterium. There are trials with lactobacillus alone. None of them shows a significant reduction in adverse outcomes. Some people say that means you've got to use a combination, but personally, I'm not so sure about that. If you look at the animal data, if you give a single strain bifidobacterium to experimental animals, you can still increase the diversity of the flora in the animals given the probiotic. So it's really not clear. We have a lot of questions. Safety, I don't want to go overboard about. This is, given many of the therapies we use, this is probably pretty good. None of the trials reports any complications at all. But there are reports of lactobacilli septicemia in children. Interestingly, the Israeli team were very keen not to use a product with a lactobacillus in it because of that risk. They can be a bit tricky to treat. At the time that I first became interested in this topic, there were no reports of bifidobacterium septicemias. There are now two. They're both of them rather strange. This is a big Japanese baby who had an exomphalos and had a mild illness which got better, and it was really after the baby got better. Bifidobacteria, as I've already said, are sensitive to penicillin, that they realised what the offending organism was. This is a more recent report on a little, very complicated baby who actually had a septicemia with an organism that wasn't meant to be in the product that the baby was being given. Now that brings me back to another point, which is none of these trials is performed to a standard that the FDA or indeed the EU regulatory authorities would expect, and none of these trials is performed with a trial certificate. And we have to take at face value that these babies have been given what it says on the side of the jar. But we don't actually know that. And as I say, this baby grew an organism which actually wasn't meant to be in the product it was being given. Where it came from, we don't really know. Products which are provided by companies that produce them as food supplements, and they're given as a food supplement, right, okay. And so they don't come under the IRB approved, but they don't have to have a formal. That's right. That's right. Absolutely. And at the moment, we have no products that are produced to a standard, and we happen to be doing a trial with a certificate, but the Australian trial, which I'll come on to, which finished recruitment, they did a lot of local quality control. But none of the actual products is certified. And that's, of course, been a problem, I think, in the United States, isn't it? We have this nasty experience which took place in the Netherlands, which is an adult trial. Patients with acute pancreatitis, obviously very ill patients. And it's a slightly strangely designed trial. It uses a mixture of different strains with several different strains of a lactobacillus in there. And in the first instance, the intervention was put directly into the jejunum, which is a slightly strange thing to do because, of course, that's a bit of the bowel which normally doesn't have very many bacteria in it. There's been a lot of criticism subsequently of this trial about the monitoring and the trial design, but the nasty shock was that when it was analysed, there was increased mortality in the active intervention arm, and that, of course, has blocked trials of probiotic use completely, as I understand it, in the Netherlands. And you might say, well, these aren't like our little babies. But if you think that the highest risk babies, those babies with leaky gut, those babies who are really difficult to start feeds, if you accept the argument that they've been excluded from the neonatal trials, then the worry is there. It hopefully is not a real worry, but the worry is there that those little babies are more likely to get probiotic septicemia than the babies who've been included in the trials. Now, against that, there is an Australian trial which has recently finished recruiting, which is, I think, recruits babies at 31 weeks and below, and obviously they went through to full recruitment with no real problems. We're running a trial which has, I hope, much higher risk babies in it, and we've got 700 babies in the trial now, and we've certainly not had any septicemias. So if it is a risk, it's a very low risk. And if it did happen, it would hopefully cause a trivial illness which we could easily treat. But I think that is certainly a safety cushion I felt that I wanted to know. Some people say to me, oh, don't be silly. You know, you're being really daft, because these are things that babies are meant to get in their gut. But actually, there aren't very many data. But those estimates that I've managed to get of the numbers of organisms which a baby would normally ingest, the rate at which a baby would ingest bifidobacteria, for instance, breastfeeding, many orders of magnitude fewer than the numbers that we're giving in these preparations. The way we're using them is not the way a baby would normally acquire probiotic strains. So I'm making it sound rather alarming, and hopefully it is safe. I mean, I don't want to particularly alarm people, but I think we just need to be conscious that it is an intervention unlike the other interventions that we use. It will inevitably spread. The organisms will adapt. There are some worrying stories coming out of Japan where probiotic use is fairly widespread, not universal, but fairly widespread, where in one particular unit where I was talking to people, they'd used a single strain, bifidobacterium, but they were beginning to see the emergence of a lot of multiply-resistant enterobacter on their units, and were wondering whether they didn't need to change the probiotic they were using. And it's quite likely, because bacteria swap antibiotic resistance genes around, and it's quite likely that we might see changes over time. And of course, such things are very, very difficult to monitor. It's very difficult to know really what's going on. So I think we have to accept, if we are going to introduce probiotic use widely, we have to accept that there will inevitably be changes in the bowel flora of the babies, and it's very difficult really to know what the significance of that may or may not be. It is, of course, the case, although I was just going to come back to that. So I want to sort of just pull this together, and where are we now? Well, there's no question that the results of the published trials are encouraging. They're encouraging that probiotics will help us with the problem of necrotizing enterocolitis and possibly reduce death. I'm concerned, though, that for the babies that I'm interested in my unit in the UK, that I don't really have data for babies like that from these trials. It's also the case that we've got virtually no long-term follow-up. The first Taiwanese study has published some data about neurodevelopment, but no data about whether or not the children given probiotics early on are different in terms of atopic phenomena, immune phenomena. We just don't know, and it's very interesting to speculate about that. The Australian trial has got some aspects along those lines built in, and certainly we plan to get our heads around that, but we won't be looking at the children certainly for quite a bit. There are, of course, examples around the world of places where probiotics have been introduced for various reasons. There's the classic study from Colombia. I don't know what the unit looks like. Huge numbers of babies. I don't know if it's crowded, but I suspect very crowded. And as I've already said, I think we might not find the same effects in different sorts of neonatal units. And this was a comparison with historic controls, reporting a dramatic reduction in adverse outcomes. Interesting experience in Finland, where Lactobacillus GG was introduced in a Finnish hospital, where they were worried about their rates of NEC, and they didn't find any difference, and they remained the tertiary unit with the highest incidence of necrotizing enterocolitis. And then, of course, the Italian experience with the same organism, the Lactobacillus GG. But really, these are reports of safety. Certainly, the introduction of Lactobacillus GG doesn't seem to have produced any problems, but these are units where the background incidence of necrotizing enterocolitis is fairly low. It's certainly lower than in our big tertiary units in the UK. And they don't publish and don't claim that say they can't look at reduction of necrotizing enterocolitis. So these are safety data rather than efficacy data. So, pulling this together, necrotizing enterocolitis is a very real problem for us, and I would group late gram-negative sepsis, quite frankly, with that. It is a major problem. The pathogenesis seems to reflect an exaggerated immune response within the intestinal mucosa. It's probably exacerbated by an imbalance of the organisms there relating to and an immaturity of the innate immune system. Treatment of the established disease, I think, is unsatisfactory, and we need preventative strategies. I don't want you to think I'm being particularly gloomy. I think probiotics are by far the best bet at the moment we've got. It may be that they'd be better used in combination. It may be They'd be better used with a prebiotic, an oligosaccharide or something to help them become established. It may be that lactoferrin should be given with them. We're years off knowing the answers to those questions. I personally think that we need more evidence than we've got. We need some big, well-designed trials. But even when we've got those, we're still going to have a lot of outstanding questions. Now, my understanding of where we are at the moment, and it's quite possible that some of you know more about them, things that are going on that I don't know about. I'm aware of two big randomised control trials. One is the Australian trial, which has finished recruiting. I rather hoped that the data might appear as a late breaker at the recent PAS meeting, but it didn't. It wasn't ready. I think it will be shown for the first time at the EAPS meeting in Istanbul in October, to which I wasn't going to go, but I think now I'm going to. They completed recruitment. Certainly they had meetings of their data monitoring committee when they got about 700 babies, and they carried on recruiting. So presumably they're not showing huge differences. Their primary outcome is sepsis rather than necrotizing enterocolitis, but it will be really important to see those results. They're using a product with a mixture of organisms in it. Our own trial has recruited 700 of target 1,300 babies with the primary outcome, three primary outcomes of NEC, blood culture positive sepsis, but excluding the skin commensals and death. With a single strain of bifidobacterium, which nobody else has actually done, and starting it, whether or not the babies have started milk feeds, and trying to start it earlier, but not as early as I would have liked. I understand that products that the FDA, and people are working with the FDA to manufacture products in the States that will be able to go forward for trials, but you probably possibly know more about that than I don't know anything about it.
They're trying to get them on the market. The problem is that some of the people that were involved in doing the meta-analysis were also involved in trying to get a product out.
Yeah, well,
we just finished, we're publishing in Pediatrics a trial with 750 babies.
Oh, there you go.
That's with lactobacillus reuteri.
Right.
But that probiotic it comes from a laboratory where it's been studied very, very carefully.
Yes.
They've identified the genes that promote resistance. It's been
Yeah.
modified. And one of the concerns with the other probiotics is that they don't have that scrutiny.
That's right, absolutely. And are those babies recruited in the United States?
Those babies were recruited in Colombia. So the idea is that, for the issue of what you said, infection, one of what you're looking at with probiotics, you expect to affect gram-negative sepsis.
I would hope so, but nobody's published that.
Yeah, so the Dying trial, I think overall was a very good trial, but because their incidence of gram-negative infection was very low, it was very difficult to find a difference. You have to go to a place where there is high incidence of gram-negative, and that's why we decided to do it in South America.
Well, London's quite good.
Yeah. And then these other trials that are in this, I think that meta-analysis is a beautiful example of that the computer, you put good data into the computer and you get good data out. But here you're putting studies where you have a mixture, and a large percentage of them are not studies that were powered or used as an endpoint NEC. And so you can see how you can use statistical techniques to make something that's not so good versus very good. And I think that the problem with the majority of them is that they were not powered for safety. Safety, and that's
for efficacy either.
That's the neonatologist's concern. Well, it's wonderful if you can decrease NEC, but is it safe to give to immature, premature babies? And I think that's the biggest question.
I mean, it is interesting. I mean, the other two things, I mean, in Denmark, and we've got some people here from Denmark, I know that in some Danish hospitals its use has been... just one?
Yeah, in Copenhagen we use it.
That's right, because Gorm was
Gorm is very cute.
I know he is.
Yes, and we know.
Right, there you go. And the other thing, which we don't contribute to the Mont Oxford network, but I gather from Roger Sol that a question is being introduced into the Mont Oxford, so that at least we know how much probiotic use is taking place out there, and that in itself will be absolutely fascinating. But with your trial, I don't know what your trial shows, I'll buy you a drink later on. I don't know what your trial shows, but I suspect with your trial, with my trial, with the American trial, even if we finish my trial, we are still going to have masses of questions. And one of the problems, I think, is that we inevitably have spread within our hospitals. And, you know, the idea that we're going to have to do cluster randomized trials is challenging. But with an intervention which is like this, it may well be that that's the way we're going to have to go, because we're still not going to really know what product is best or how long we should give it for. I mean, there is some lovely data, lovely little paper from Cork, that if you can actually stop using antibiotics, one dose may well be enough because they get established and off they grow and multiply. But if you keep giving antibiotics, you'll need to keep topping up your probiotics. So masses of questions, and surveillance is a very interesting, or how you really monitor the effects of making these changes, and we quite possibly never know. So thank you very much. I'm interested in feelings. I'm interested in what's going on in Italy.
Well, we know about the Carlodan trial in Florence, that is in some way used to perform a single-center trial.
Yes, yes.
And also the work of Manzoni.
Yes, yes.
We wait for some confirmation from outside.
And in Denmark? Just the one hospital still?
No, it's all over Zealand, I think. One of the islands,
Right.
all of them use it.
Sorry, sorry.
So I guess thinking about, you made the point about safety, and this is really a prophylaxis treatment, and 8% in general of preemies get NEC, so a lot of babies who aren't at risk for NEC are going to be getting this medication. So safety really
That's
needs
right.
to be established.
I mean, perhaps you don't need to give it to less than 1,500. I mean, you possibly should be giving it to below 28 weeks or something.
Yeah, but I just
But,
wanted, I mean, that's just something
yes,
important to keep in
it's a
mind.
general
And-
point, very
And I guess
important
the other
general point.
thought that I had is even if, you know, these individual trials prove safety of their product, because it's not standardized, for us to generalize it and say, well, I'm going to the health food store to get my product, that's a different product than what was studied. So unlike EPO or whatever, you know, where it's FDA approved, you know what's in the bottle.
Well, there's a horror story going around England, which I thought at first couldn't be true, but is true. I've seen the evidence that a particular product, which some people were quite keen to start using, and have got in their drug cupboards, but haven't used because somebody thought they ought to do some quality control, and on 2 occasions grew a Bacillus cereus. And thought, hey,
Yeah, be careful.
because, you know, there are organisms which in adult medicine people might not worry about, but which in, you know, a compromised, really sick little baby can be a serious pathogen.
Another thing is the culturing of this is very, very, very difficult. If you look at the papers that have
That's
been published,
partly why there's so little reporting of the colonization.
the methodologies don't describe how they try to recover and identify the, you know, if there's a possibility of an infection by the probiotic. But usually we were able to see that they grow, but at the bottom of the Bactec plus Keats culture bottle, where there's lower concentration of oxygen. But it takes, in many cases, 72 hours or more to grow. So if you're stopping at 48 hours or 72, you might not catch it. If you do gram stains, you might see the bacillus of sporin-like that would suggest that it could be a continental infection, a probiotic infection, and then you would have to then put it in an anaerobic culture and then do genetic testing to be able to say that it's the same probiotic that you're giving. And it's very expensive because the majority of the children's hospitals are not doing cultures for anaerobes anymore because of the low yield that they had. So the technology is very expensive to do, so people are not doing standardized protocols to identify these organisms to see if some of those infections that are babies clinically look septic, but the blood culture is negative. Those are the ones you would like to grab and do the whole thing, but they couldn't do it because that's the majority. It's very, very expensive to do. So there's a lot to question, a lot of our studies and all the studies that have been done on the safety of it, because we're not really...
It's different. I understand it's different with bifidobacteria, which are relatively easy to grow. Because the product we're trialing is, as I say, a single strain bifidobacterium. And the microbiologists seem fairly confident that it would be spotted. We would then have to type it and do all the fancy stuff and confirm that it was the organism we were actually giving. But that it's relatively easy. We are in our trial, we are culturing the stools of all the babies at 2 weeks and at 36 weeks. So we will know which ones were actually colonised. And we know we've got cross-colonisation. I mean, when we started out, I thought we'd have some outlying hospitals and we'd be able to go in then and reinforce the training and things. But in fact, it's fairly uniform. But we're just trying to sort of, implore all of them to get really strict about not just washing your hands before and after you touch a baby, but before and after you touch everything around the baby, because we know that on the 36-week stool sample, 70% of our babies colonise with our bifidobacterium.
All the babies?
70% of the babies in the trial, these are blinded data, are colonised. Now that's probably true of all the trials.
So that decreases the potential to find a difference.
Of course it does. Of course it does. But which is why, as I say, it's possible that the benefits of probiotics are understated in these trials. Because I don't think it's only us that has cross-colonisation between our groups. Everybody will have, but people haven't measured it.
So do you think there's a clue in the gestational age data that you showed?
It's very interesting.
I mean, it's sort of reminiscent of
It's
ROP,
It's
right?
a bit like a developmental, I think as people have cottoned on to this, so people are really looking at what's going on in terms of the development of the intestinal immune system at about that point in time.
Yeah.
Because I think those data are very important as a lead. I'm sure it's a clue, and I think lots of people are very excited. I mean, it's only really become clear in the last few years that that's the case. I don't think we didn't twig that. We began to twig that we were seeing it later in more preterm babies.
Mm-hmm.
But, the fact that there is this peak that is so, it just makes you think, hey, this is some developmental thing at that time. Something's switching wrong or doing something wrong.
I was surprised about that peak at 32.
There's another lovely data Lanos et al. A couple of years earlier showing exactly the same thing. Very interesting. I mean, those data they got spotted a couple of weeks ago, but there are some other ones around. Very interesting.
That's about the time you're supposed to get in home.
32 weeks?
When you're beginning, it's when you think we're there.
Get out
Yeah.
of the
We're
unit.
there. We're
That's
putting you
what I'm
down.
talking
That's right. That's right.
That they're
How
going
do
to
you
get
know?
out.
You go into the unit in the morning and we've had a terrible
30,
nonsense of it.
because we were talking about some of the babies go home between 34 and 35 weeks, but if you're at 32 weeks, you're not really concerned about NEC happening at that time, so it is interesting.
Well, in your trial, how long did you carry your intervention on for? When did you discontinue it?
The babies were started within the first 48 hours of life, even if they had not gotten these, they were started, and they were given that until they were discharged.
Right. I think through. That's it.
Tomorrow morning.